Good evening. I want to welcome everybody to this week's Sagis Happy Hour. Sorry, I'm going ahead and just opening up my chat so I can take questions here. Anyway, I want to welcome everybody to this week's Happy Hour session. We'll be doing a potpourri here. If you're attending the session live, please feel free to throw out any questions into the chat. Then I'll get around to answering them, and I can't imagine I wouldn't. You can always send them to education@sagisdx.com, or you can email me directly, tdavis@sagisdx.com. Don't mind a call or a text either. My cell phone is 210-416-4815. I wanted to point out again, as always, if anybody listening to this has any suggestions for topics that they'd like us to address in one of these happy hour sessions, and it doesn't even have to be Dermpath, please feel free to shoot us an email. We're always looking for suggestions. With that in mind, I'd like to point out that next week we are going to be releasing an interview that I did with Dr. Chris White. Chris is a dermatologist in practice in Ohio who finished his dermatology residency just last summer, 2021. He's 9 months out, and I thought that he would probably be in a unique position to help any of our upcoming graduating residents who might have any questions about the transition into private practice, and even for some of the PGY3s and PGY2s. Among other things, he's going to be talking a little bit about the applied exam and how he prepared for it. And he'll also be talking a little bit about things that he wished he had known going into private practice, things he was glad that he had done. And then he'll close out a little bit talking about work-life balance, which I think is always a difficult thing to juggle. But I think it's, these are issues that if you consider before you go into private practice will make the transition that much easier. So I would encourage you to watch that. So we'll go ahead and get started today. We've got a good collection, I think, of inflammatory, neoplastic, and depositional disorders. I do want to apologize. Some of the slides in this week's deck are a little bit pale staining. We are testing out a new scanner, and even with 3 scans and some software tweaks, some of the slides still ended up being a little pale. That being said, it's good practice to work through looking at some images which may be less than ideal, because certainly under testing circumstances you're not always going to get the best examples, and this is very real life. So we'll go ahead and get started with our first case. Case number 1, the correct diagnosis excuse me, is coccidiomycosis. The specimen was a fairly sizable punch biopsy, trunk or proximal extremity. And even at low magnification, one could see that the action is really down in the deeper reticular dermis and subcutaneous tissue. There's an infiltrate here, and there's quite a bit of fibrosis that's extending into the subcutaneous tissue and kind of disrupting the normal architecture of the fat. If we move to higher power, we began to see that the infiltrates actually mixed. There are collections of lymphocytes and histiocytes. And in the presence, or in the central portion rather, of some of the collections of histiocytes, there are neutrophils forming small abscesses. And so in essence, we have suppurative and granulomatous inflammation. And remember, that's one of our types of granulomatous. Now, the most common cause of suppurative and granulomatous dermatitis that we as dermatopathologists see in skin biopsies is ruptured follicle or ruptured cyst. However, we always need to keep in mind that most infectious conditions, or a number of them that involve the skin, will induce suppurative and granulomatous dermatitis. So we're always on a bug hunt when we see that, unless we see an intact cyst that's ruptured. Indeed, if you started looking around in these sections, you began, I'm going to have my pencil here, you began to see the organisms. These are the spherules of Cocci. They're actually quite large. Our lymphocytes here and RBCs are in the range of about 5 microns. So you can see that this organism is, 40 plus microns in diameter. It's got the refractile capsule and kind of the lacy blue-gray cytoplasm that we associate with coccidiomycosis. If you start looking around, you can see a few more of these spherules. Some of these are empty. There maybe were 1 or 2 with a few endospores. Now, when you are confronted with a possible infectious disease, and certainly when you're taking a board examination, you're going to see a list of organisms. So I would encourage you, before you take your core or your applied exam, just flip through Elston's book or Whedon or Dr. Rapini's text and look at the organisms, photomicrographs or online, to get an idea of what the morphology of the organisms is. And also have a good idea of the size of the organisms. And again, you can always figure out how big they are in the tissue sections by using your lymphocyte or your RBC as a ruler. Also a good idea to kind of remember what particular type of inflammatory response the particular infectious organism tends to induce. For instance, we know that chromo always induces pseudoepitheliomatous hyperplasia with pus. Blastomycosis also associated with pseudoepitheliomatous hyperplasia with pus. Atypical mycobacterial infection, other than Hansen's, tend to produce suppurative and granulomatous inflammation, histo and leash parasitized histiocytes. So I have an idea too of the type of inflammatory response that you see. And then finally, know where to look. Sometimes with these infectious processes, you have like tons of inflammation in the dermis. The high yield areas where you're likely to see organisms are in 1, zones of necrosis, if there are any, 2, in the center of neutrophilic microabscesses, and 3, in the cytoplasm of multinucleated histiocytes. If you've got a real well-defined focus of granulomatous inflammation, a big collection of epithelioid histiocytes, don't waste time looking there, because usually that implies that the host is mounting a pretty good immune response. So those are kind of low yield areas. So case 1. We'll go ahead and move on to case number 2, and we'll kind of talk about cases 2, 3, and 4 together in tandem. So case number 2, the correct diagnosis was squamous cell carcinoma in situ. This is a shave biopsy from broad shave from sun damaged skin, and it was kind of bread loafed at the time of grossing. And as we move into higher power, these slides again are somewhat monochromatic. It's kind of like looking at an old black and white film. One can see there's quite a bit of solar elastosis in the epidermis, and the epidermis is markedly acanthotic. If we look over at the edge, we can see that there's evidence of early epidermal maturation. We have a basket weave cornified layer, and the keratinocytes are flattening out as we move up towards the granular and cornified layer. If we look in the central portion of the specimen, however, different story here. You can see that there's full thickness keratinocytic atypia here. These cells certainly are not flattening out. Some of the nuclei are pleomorphic, a few are hyperchromatic, and in the upper portions of the spinous layer, we have pagetoid cells. These pagetoid cells, by definition, are large, with large nuclei and abundant pale to clear staining cytoplasm. And so, we can see pagetoid cells in things other than Bowen's disease. So, our differential when we see this picture could be melanoma, could be extramammary Paget's disease or Paget's disease, the two of which you cannot tell apart. I have some people raising their hands here. If you want to, go ahead and type your questions into the chat if you can, and then I can answer them. So Paget's, extramammary Paget's. You can also see clear staining cells in things like sebaceous carcinoma as well. But the key differentials here with this type of picture are melanoma, Bowen's, and Paget/extramammary Paget's disease. One clue to the diagnosis of Bowen's disease in this particular instance is the fact that we have full thickness keratinocytic atypia. In some areas, and I may need to go to another section, there were even atypical parakeratotic cells in the stratum corneum. And none of the other conditions, melanoma or extramammary Paget's will be characterized by full thickness keratinocytic atypia. Yes, you can see Pagetoid cells, but if you look at the epidermis between the Pagetoid cells, you should see evidence of orderly maturation in Paget's and extramammary Paget's, and we'll take a look at that in the next case. With regards to melanoma, melanoma begins at the DEJ, and so you're going to see a proliferation of atypical melanocytes along the DEJ or nested aggregates at the DEJ. You can get Pagetoid scatter, but you should see these melanocytes at the DEJ. And again, you won't get full thickness keratinocytic atypia. And then, of course, finally, we can use immunohistochemical stains to distinguish these entities. Melanoma, of course, would be positive for melanocytic markers, S100, SOX10, melanae. Paget's should be positive for cytokeratin 7, as should extramammary Paget's. And Bowen's disease will be P63 positive. So hopefully that discussion helps you out there. With that in mind, we'll go ahead and move on to case number 3. And case number 3, got a little bit of a merry-go-round going here. The correct diagnosis was extramammary Paget's disease. In this punch biopsy specimen, one can see abundant hemorrhage. And if you, as we recommend, took some time to assess anatomic location, you should have picked up on the fact that this was a special site scan. We have a tremendous number of smooth muscle bundles present within a somewhat edematous dermis. And we've got no follicular units here. We've got some ductal elements. We've got a little ductal lumina here and a little bit of an acrosyringium, but we don't have any hair follicles. And this was a biopsy specimen from the groin. Some similarity to the case of Bowen's we looked at. The epidermis is extremely acanthotic, and obviously, excuse me, the epidermis is peppered with Pagetoid cells here. These cells with abundant pale staining cytoplasm and large and somewhat atypical nuclei. In this particular instance, we have nice compression in areas of the basal layer, which help us to rule out melanoma as a likely possibility. And getting back to what I was pointing out before, if you look at the epidermal keratinocytes in these sections, which are located between the Pagetoid cells, you can see that for the most part, the epidermis shows evidence of orderly maturation. We have an intact granular layer here and orderly maturation of keratinocytes, a finding which we weren't seeing in squamous cell carcinoma in situ. Furthermore, this is a biopsy from non-sun damage scan. And a finding that we see frequently with melanoma and also with Paget's, extramammary Paget's, and not so much with Bowen's, is we see a spinning of the Pagetoid cells out into the stratum corneum. So in Bowen's, the cells will partially keratinize and the nuclei will flatten out. Here you can see you have direct extension of these Pagetoid cells into the overlying epidermis. And again, these cells would be cytokeratin 7 positive. So it never hurts to look at a lot of examples of Bowen's versus extramammary Paget's versus melanoma. It's a differential you can count on being tested on the core examination. Okay, let's go ahead and move on to slide number 4. This was another condition characterized by the presence of a number of clear staining cells within these sections. Again, a little bit of a pale stain. This lesion is obviously clinically was a dome-shaped papule, and it kind of has a benign architectural configuration. As we move into higher power, and again, it's a little difficult because of the pale nature of the stains, sections, we can see a number of collections of clear staining cells in the dermis. These have uniform nuclei, very abundant cytoplasm, not much granularity, a few are multinucleated, and first blush, it's kind of like, what are these? Is this a weird granular cell tumor? If we look over at the edge, we can see that we've got very banal appearing melanocytes arranged as nests within the papillary and diverticular dermis. This lesion was entirely intradermal. If this were compound, one would expect to see nested aggregates of uniform melanocytes at the epidermis. Well, that really tells us that we're dealing with a balloon cell nevus. These cells are admixed. Balloon cell change, as I'm sure many of you know, is a degenerative change. And if you look ultrastructurally at these cells, you just see swollen organelles at the cellular area. There's no atypia here. We've got maturation with depth. And so what we have here is a balloon cell nevus. Now you can get a balloon cell change in melanomas as well, but the lesion itself, the melanocytic lesion, will have many of the attributes of melanoma with upward scatter, lack of maturation with depth, marked variability in the size and shape of nest and cytologic atypia. I will say that I've never seen either a balloon cell nevus or balloon cell melanoma where 100% of the melanocytes were ballooned. So there will always be an admixture of more banal appearing melanocytes, which will allow identification of a balloon cell nevus and a balloon cell melanoma. Okay, moving on to case number 5. This was another condition in which one had a proliferation of kind of clear staining cells. Actually, 5 and 6. 5 and 6 are two entities, excuse me, which are characterized by accumulations of lipid-laden histiocytes or foam cells or xanthoma cells. One useful clue to getting at the correct diagnosis in this case is recognition of this as eyelid skin. Okay, there aren't too many anatomic locations that have the attributes that this particular site does. The epidermis is quite thin. If we move to higher power, we can see we've got a marked increase in the number of vellus follicular units. The dermis itself is kind of loose and edematous. The collagen fibers are a little bit wispy and thin, and we have skeletal muscle on the dermis. And that combination of features is very suggestive of eyelid skin. And really, when you think about it, there aren't too many reasons that people biopsy the eyelid. Occasionally you'll see melanoma or a carcinoma there. The most common biopsies that I see from the eyelid are either for xanthelasma, vermilia, or for hydrocystoma. Certainly not everything, but when you do see biopsies of eyelid skin, chances are you're going to be dealing with one of those diagnoses. And indeed, if we look at the infiltrate here, we can see we've got these round, variably sized shapes of foam cells, collections of foam cells. These cells have very uniform round oval nuclei. They have lipid vacuoles in their cytoplasm. Notably absent in the dermis here are an appreciable inflammatory infiltrate and extracellular lipid. And it's the lack of those two things which allow you to distinguish this from an eruptive xanthoma. Another feature that I found useful with identification of xanthelasma. If you look at the nuclei here, the foam cells themselves have variable numbers of nuclei. A lot of them have a single nucleus. Here we've got one with 2, Here's another one with 2 nuclei. Here's one with 4 nuclei and are abundant foamy cytoplasm. They bear a vague resemblance to domino tiles. And so when I see a proliferation of foam cells and I start thinking about domino tiles, I also think about the possibility of xanthelasma. So xanthelasma, high yield slide, frequently asked on board exams. Slide number 6, move to that one. The correct diagnosis was Verruciform xanthoma. This was a little bit different than some of the Verruciform xanthomas that we see. The specimen was a trisected shade biopsy. The epidermis is acanthotic here, but it's not as papillomatous or doesn't have quite as a verrucous surface as we see in some Verruciform xanthomas. As a result, what we don't have in this particular slide, and it can be a useful clue to the diagnosis, are the wedges of eosinophilic parakeratosis pointing down to the widened dermal papillae. On high power, we do have collections of neutrophils within the epidermis, which we do frequently see in the setting of a Verruciform xanthoma. Here, these are forming spongiform pustules. And so at first blush, you might think, oh, is this pustular psoriasis, a florid form of pustular psoriasis, or do we have a dermatophyte infection or florid candidiasis? But if you do look in the dermal papillae, you can see that they are widened and there are clearly identifiable foam cells within the dermal papillae. So just kind of an unusual variant of a Verruciform xanthoma. This lesion was occurring within the setting of a lesion of child syndrome. And so perhaps that's why this histology here was different. But I just wanted to share this case of a Verruciform xanthoma. Neutrophils in the epidermis can be a clue. And again, the widened dermal papillae containing foam cells. If you see it on a pick list, you want to immediately go to the dermal papillae and look for the foam cells. Okay, let's go ahead and move on to our next case. Case number 7. We're going to, in cases 7 and 8, we're going to be looking at 2 examples of acantholytic disorders, particularly 2 conditions demonstrating acantholytic dyskeratosis. And if you haven't had a chance to watch in the Sagis YouTube library our video on epidermal reaction patterns, it's just a quick 15-minute talk. I would urge you to take a look at that because I discussed some of the differential diagnosis of focal acantholytic dyskeratosis and epidermolytic hyperkeratosis. In this punch biopsy from the truck, the epidermis is somewhat acanthotic, and hopefully you were able to pick up on 2 discrete and small foci of suprabasilar acantholysis. Both did show some dyskeratosis, a little bit more subtle in this focus on the right. There are a few dyskeratotic cells up here in the granular or cornified layers, so-called grains, and a few corons and grains here, acantholytic dyskeratotic cells. And so we clearly have FAD here. And when we see pronounced dyskeratosis, that allows us to eliminate pemphigus and Haley-Haley as diagnostic possibilities, because neither one of them, although characterized by suprabasilar acantholysis, shows pronounced dyskeratosis. So we're probably dealing here with either incidental FAD or an isolated keratosis with FAD. Maybe the patient has more than one. These could be acantholytic acanthomas or acantholytic dyskeratomas, or, conceivable, we could be dealing with Derry's disease, although usually the foci of acantholysis are more uniform, or in this particular case, we were dealing with Grover's disease. Now, the only way we can really arrive at that differential is by correlating with clinical findings. You really can't distinguish those entities reliably in the absence of clinical information. That's why you should never see Grover's and a Derry's and an acantholytic acanthoma on the same pick list. If anybody ever gives you a test like that without any clinical data, it's a bad question. I just blow it off. So anyway, this was an example of Grover's disease. And remember, Grover's can show a multiplicity of patterns. You can have biopsies that look like Derrier's disease, biopsies that look like Haley, biopsies that look like pemphigus, and biopsies that look just like an eczematous dermatitis. So it really does require clinical pathologic correlation. Case number 8 was a warty dyskeratoma. And warty dyskeratomas are basically just dilated follicles or cysts or ductal structures in which there is associated focal acantholytic dyskeratosis. And so in these sections, we have a large cup-shaped invagination. It's actually more of an acanthotic epidermis derived in part from follicular epithelium. And we've got a lot of parakeratosis in the stratum corneum. And as we go down to higher power, we can clearly see there's acantholysis here. The keratinocytes are separating from one another, they're rounding up, and some of them are dyskeratotic. So we have FAD here. And the key differential here is, are we dealing with a warty dyskeratoma, or are we dealing with an acantholytic squamous cell carcinoma? Now, if we look at the keratinocytes here, they're not very atypical. The nuclei are mildly pleomorphic, but we're not seeing a lot of mitotic figures. We're not seeing striking nuclear pleomorphism. We're not seeing mitotic figures in number. And there's a little bit of solar elastosis, but typically when we get an acantholytic squame, you expect to see some actinic keratosis or keratinocytic atypia in the adjacent epidermis, and we're not seeing that here. So taken together, these features are diagnostic of a warty dyskeratoma. Case number 9 was a nice example, I thought, of a dermatomyofibroma. And in this punch biopsy from the trunk, one can see that we have an infiltrate in the dermis. The epidermis is mildly acanthotic. And if we go down and take a look at the infiltrate, we can see that this lesion does extend to both peripheral edges of the biopsy specimen. So we can't really assess the entire architecture of the lesion. It does seem to kind of be situated in the mid-to upper reticular dermis, so it doesn't appear to be infiltrating deeply into the underlying dermis. And notice a key feature here. There's preservation of the adnexal epithelium and the eccrine coils. So this tumor is kind of doing what a neurofibroma does. It's hitting the adnexal structures and coursing around them, growing around them. That's distinctly different from what we see in a dermatofibroma, and a lot of times even with leiomyomas. They'll tend to push the adnexal structures out of the way. This particular neoplasm, as we move to higher power, we can see is composed of these kind of sweeping vascicles of spindle cells. The spindle cells have very uniform nuclei. Some of them are kind of plump on the end. Others are kind of tapered. Some of the vascicles are cut longitudinally. Others are cut in cross-section. The ones cut in cross-section have, as expected, round nuclei. But if we look at the orientation, overall orientation of these vascicles, even though some are cut longitudinally, some are cut in cross-section, they're running parallel to the dermal epidermal junction. And of course, it's this east-west growth pattern or orientation of the vascicles and the sparing of adnexal epithelium that should really clue you into the diagnosis of a dermatomyofibroma. This is a proliferation of myofibroblasts. Another subtle clue here, and sometimes you see it and sometimes you don't. Hopefully this will project for you. But if you zoom into higher power, you can see these refractile elastic fibers, which you normally can't see that well on H&D stained sections. I'm going to see if I can circle one here with my pencil, between the spindle cells. And if we do a VVG stain on this, an elastic tissue stain, you see an increased number of somewhat thickened elastic fibers between the spindle cells in a dermatomyofibroma. These will also sometimes show a membranous decoration with SMA, but but this is a very characteristic appearance of a dermatomyofibroma. Again, items that are in the differential are a dermatofibroma. The fascicles in a dermatofibroma are much more haphazardly arranged. You see collagen trapping, frequently epidermal hyperplasia, and obliteration of the adnexing. Also with a smooth muscle tumor, again, that you tend not to get adnexal preservation, and the fascicles of smooth muscle are a little bit more randomly oriented. The nuclei tend to be larger, more blunted, and of course you can see the perinuclear halo or halos or glycogen stacks. Moving on to slide 10, slide number 10, couldn't have a session without doing an interface dermatitis. Okay, we have a punch biopsy here, and this was from the trunk, and there's an inflammatory infiltrate around the superficial and mid-dermal plexus here. As we move into higher power, we can see there's basket weave cornified layer. There's vacuolar change along the DEJ. And I think very quickly you could pick up that there was a lot of pigmentary incontinence, a lot of melanophages within the dermis, okay? Now with the basket weave cornified layer, the vacuolar change, the pigmentary incontinence, I'm thinking, could this be EM? EM and skin of color can be associated with a lot of pigmentary incontinence. But, we need to look at the infiltrate, because if we start seeing a lot of eosinophils, we're going to have to think more seriously about a fixed drug eruption. The two of them can look a lot alike. And, even with the pale stain, I think if you looked, you could begin to see a fair number of eosinophils. Here we can see the eosinophilic granules. There's another one over here. Here's one over here. Bilobe nucleus is the key here. The cytoplasm's a little bit paled out. But if you move along the DJ, I think you could start seeing a fair number of eosinophils within the infiltrate. This particular slide did not have a lot of necrotic keratinocytes within the epidermis. There were a few. Fixed drug normally has a few more necrotic keratinocytes, as does EM. But this was a nice example of fixed drug eruption. Okay, case number 11. Case number 11 was a real pretty example, I thought, of mast cell disease. It's a much darker staining slide, bisected shave, a lot of crusting on the surface. As we move into higher power, we can see that the epidermis is hyperplastic, and there's a nodular collection of cells in the dermis. And anytime we're dealing with a nodular infiltrate, the differential is predicated on identifying the cell type. Well, one thing that's very striking at higher or at lower power with this infiltrate is it's very monotonous, very uniform. And as I move down to higher power and I start seeing an infiltrate that's very monotonous and uniform with very evenly spaced cells, two things I always think about are mast cell disease and congenital melanocytic nevi. Okay, those are two conditions that are going to give you very monotonous cells. And if we go in and take a look at these cells, for one, we start to see a few eosinophils within the infiltrate. And I start seeing eosinophils within the infiltrate. I'm thinking more about mast cell disease than melanocytic nevus. And then these do have kind of a fried egg appearance, very uniform nuclei, abundant cytoplasm. And even at this power, and we can zoom in, some of these cells do have granules within their cytoplasm. Let me see if I can zoom in, and we can pick that up a little bit. We may get too much pixelation, but go back and take a look at the cells, and you can see some granularity here. Of course, we will confirm the diagnosis with CD117 c-Kit or a mast cell tryptase stain. And these cells would stain very strongly. Okay, and we'll close out our discussion with slide number 12. Slide number 12 was obviously an example of nil disease, or the normal skin differential. The correct diagnosis in this case is Argyria, kind of rare hen's teeth. I'll only see a case of this about every 10 years or so. And the diagnosis was predicated on going down and looking at the basement membrane of the eccrine coils. And if you do, you can see they're outlined by small little black granules. It's kind of like subtle eyeliner surrounding each one of the eccrine coils. It's a little bit of pigment accumulating in smooth muscle, which is kind of odd. I didn't see too much in blood vessels. That's another area. You can see it in the basement membrane of blood vessels. And sometimes it'll deposit on elastic fibers as well. But this is Argyria. And, again, obviously, when we do see a biopsy that's showing not much on scan, if we don't see much of an inflammatory infiltrate, no epidermal change, or not much in the way of alteration of dermal collagen, you just have to start going down in high power and top down, look in the cornified layer to make sure that there are no filamentous bacteria or fungal elements there. You want to see if the granular layer is intact. Make sure you're not dealing with ichthyosis vulgaris. Look at the epidermis, see if there's melanin pigment there or melanocytes. You might be dealing with a subtle expression of vitiligo. That can be kind of hard in H&D stain sections. Sometimes we'll need to do a Fontana and a Melanase stain to make that diagnosis. You can go down and make sure you don't have a subtle expression of mast cell disease. That can also be difficult without use of mast cell tryptase or c-kit stains, because the mast cells can sometimes spindle out. You want to make sure that there's no amyloid in the papillary dermis, that you don't have a subtle increase in the amount of dermal mucin, that you're not expressing, that you're not missing a subtle dermal melanocytosis like nevus vota. You want to make sure that you've got eccrine coils present. You don't want to miss ectodermal dysplasia. And then you can start looking for deposits like Argyria around the eccrine coils. But you just have to be kind of systematic in your approach. But at that point, you're going to correlate with the clinical history and clinical description as well. So anyway, I hope this session was helpful. Please feel free to reach out. I think some people were trying to raise their hands, but I didn't see any questions in the chat. I also want to point out to you, many of you probably already know it, but we posted a video recently on the YouTube channel that April McDonald did. Very useful video. And it details how you can search for a given diagnosis in the YouTube library. And she'll show you in that video how to type in an entity. And you can find, it'll bring up then all the videos, all the sessions, happy hour sessions in which that diagnosis was discussed. And then you can go into those, and each one of those time stamped. And if you just click on the entity, it'll take you directly to that entity. So that way you don't have to watch the whole video. So anyway, thanks so much. Appreciate it. And we'll talk to you later. Have a good day.